coming to what? Coming to intraocular pressure or intraocular tension. Come on guys, what is meant by intraocular pressure or intraocular tension? What is meant by intraocular pressure? Intraocular pressure is the pressure exerted by the aqueous humor and vitreous humor over the eyeball is called as intraocular pressure, right? Intraocular pressure. And this intraocular pressure keeps on fluctuating. We need to understand what is the normal value of intraocular pressure. The normal value of intraocular pressure is what, guys? 10 to 21 mm of Hg. It keeps on fluctuating in a day. Okay? When I wake up, my intracranial as well as intraocular pressure is high. When I sleep, my intracranial and intraocular pressure is a bit low. At the morning time, the intraocular pressure is high, whereas at the highest intraocular pressure, once again, we'll start from here. Intraocular pressure. Intraocular pressure is a pressure exerted by aqueous humor and vitreous humor on the eyeball is called as intraocular pressure, right? So guys, remember, this intraocular pressure value keeps on changing, but before going to the value, we need to first understand what is the exact value of intraocular pressure. The exact value of intraocular pressure is 10 to 21 mm of Hg. We have seen some fluctuations in a day. When I wake up in the morning, my intraocular pressure, if I measure my intraocular pressure with tonometer, the device used to measure intraocular pressure is tonometer, which is also called as tonometry. So when I measure my intraocular pressure in the morning, it will be very high. In the night time, it will be low. I will see a fluctuation of 3 to 6 mm of Hg of intraocular pressure in a day. If the fluctuation is more than 6 mm of Hg in a day, then it is indicative of glaucoma. Then it is indicative of what, guys? Glaucoma. Right? So intraocular pressure normal value is how much, guys? 10 to 21 mm of Hg. How much of fluctuation can you see in a day? 3 to 6 mm of Hg. If it is more than 6 mm of Hg, then it indicates what? Glaucoma. And intraocular pressure is never dependent on what? The blood pressure. How will you measure the intraocular pressure? By a device called as what? Tonometry. Tonometry. Right? There are many tonometers. Schwartz tonometer is there, implantation and other tonometers are there. Okay. So there are many devices to measure the intraocular pressure. Now guys, remember, till now the devices that we have discussed is keratometry. Keratometry that is a device that measures the curvature of the cornea. Pachymetry measures the thickness of the cornea. Pachymetry, what's the normal corneal thickness? 500 to 600, on an average 540 microns. Okay. Pachymetry, keratometry. Now we have discussed what? Tonometry. Tonometry measures the intraocular pressure. Right. So just write here, guys. Intraocular pressure is what? It is the pressure exerted by aqueous humor and vitreous humor, or basically can I say it is a pressure exerted by the fluid component of the eye? Yes or no? The fluid component of the eye or fluid compartment of the eye is aqueous and vitreous humor. So it is a pressure exerted by aqueous humor and vitreous humor on the eyeball. The normal IOP, the normal intraocular pressure is 10 to 21 mm of Hg. 10 to 21 mm of Hg with an average value of 16 mm of Hg. Right? 10 to 21 is the normal value. If the value of IOP, if intraocular pressure is more than 22 mm of Hg, then it is suggestive of a disease called as glaucoma. Right? I told you in a day the intraocular pressure will be fluctuating. There will be fluctuations of IOP is seen. How many guys? 3 to 6 mm Hg of fluctuation is commonly seen. But if the fluctuation is more than 6 mm of Hg, then it is suggestive of what, guys? Glaucoma. If the fluctuation is more than 6 mm of Hg, it is suggestive of glaucoma. Right? So maximum fluctuation is how much? 3 to 6 mm of Hg. And does intraocular pressure have any role with the blood pressure? No. IOP has no role with the blood pressure. IOP has no relation with the blood pressure. Okay. Okay, more than 6 mm of Hg fluctuation, then higher incidence of glaucoma. It's already written in the notes. I told you, highest intraocular pressure is seen at the morning time and lowest is seen at the 8 p.m. And how will you measure the intraocular pressure? It is measured by a device called as tonometry. There are two types of tonometer. One is called as indentation tonometer, other is called as applantation tonometer. Indentation tonometer is Schwartz tonometer and applantation tonometer is Goldman tonometer. Most commonly we use Schwartz tonometer. The best is what? Goldman. Best is what, guys? Goldman. But again, Goldman is a bit costly device. That's why most commonly we use what, guys? Schwartz tonometer. Schwartz tonometer is commonly used tonometer to measure the intraocular pressure. Intraocular pressure. Intraocular pressure reading usually depends, or tonometry readings, it depends on the pachymetry results. Pachymetry. Why? Because I told you, right? Tonometer measures the intraocular pressure, but it depends on the corneal thickness. For every 10 microns of extra corneal thickness, intraocular pressure increases falsely by 1 mm of Hg. But this false increase of the intraocular pressure can also cause glaucoma. Okay. So, and for every 10 mm decrease, it will cause 1. Remember, if every 10 mm extra is there, 1 mm Hg will be extra added. So, look over here, guys. Imagine a patient is there who's coming with a pachymetry reading of 620 microns of cornea. What's the normal pachymetry readings? 500 to 600. On an average, we take a value of 540. Average value was 540 microns. Average value of pachymetry was 540 microns. Okay? This patient is having a pachymetry reading of 620 microns. So how many extra are there? 80 microns are extra. If we take with the average value, how much is extra? 80 microns is extra. 80 microns is extra. Right? So imagine, guys, 80 microns extra means every 10 mm, 1 mm Hg we are extra adding. So 80 microns means 8 mm Hg we have to extra add over here. So imagine, guys, this patient, imagine the intraocular pressure of the patient is between 10 to 21 and the average value is 16 mm of Hg. 16 mm of Hg, right? So this patient, average value we are taking 16, but we have to add more 8 also. Why? Because he's having an extra corneal thickness. How much? 8. So 16 plus 8, how much it becomes? 24 mm of Hg. And okay, it is suggestive of glaucoma. Basically, remember, tonometry readings depends on the pachymetry. Tonometry results depends on the pachymetry. For extra corneal thickness, 10 microns of corneal thickness, 1 mm Hg is added. Okay, guys. So 80 microns ke liye how much will be added? 8 mm Hg. The normal IOP average value is 16 mm. So here we have to add more 8 mm Hg. So it becomes 24, which is suggestive that the patient can become glaucomatous. The patient might become glaucomatous. So remember, guys, intraocular pressure depends on the intraocular pressure is measured by tonometry, and the tonometry results usually depends on the pachymetry or the thickness of the cornea. That's regarding what, guys? Intraocular pressure. Coming to the next topic, which is called as visual field. What is meant by the term visual field? When do you call it as a visual field? Just look over here, guys. Okay? Now, imagine I am telling you to focus your vision on the tip of the pen. Okay? I am telling you not to move your eyes from the tip of the pen. And while you're focusing, I take my finger and I'm asking you, are you able to see my finger? Your focus is on the tip of the pen. Okay? But I am asking you, are you able to see my finger without? Basically, visual field meaning what? It is the area of field seen by the eye without moving the eye from a fixed point. This is the superior visual field. This is the nasal field. This is the temporal field. This is the inferior field. Right? So once again guys, what is visual field? Visual field is the area of space seen by the eye without moving the eye from a fixed point. This is the superior field, this is the nasal field, temporal field and inferior field, right? Inferior field. So just write there. How will you measure the visual field? By a test, by a test called as perimetry or perimeter. Perimetry or perimeter. So first of all, just write there the definition of visual field. Visual field is the area of space seen by the eye without moving the eye from a fixed point. It is the area of space seen by the eye without moving the eye from a fixed point. How it is measured, guys? This is measured by perimetry. This is measured by not petri, it is perimetry. Now guys, look over here, right? In this visual field, we need to remember what are the four visual fields: superior, nasal, temporal, inferior. Which is the shortest visual field? Superior, inferior, temporal or nasal? Which is shortest? The nasal. Why? Because the nose is coming in between, which is obstructing the visual field. Hence, the nasal field is the shortest. Which is the largest visual field? Temporal visual field. You are fixing your vision onto this finger. And now I am asking you, are you able to see this finger? Yes. Yani ke temporal is the largest, whereas the shortest is what, guys? Nasal field. Shortest is nasal field, whereas the longest visual field is the temporal field. Temporal visual field is the longest visual field. Now guys, remember, some persons will be having narrow eyes, some persons will be having wide eyes. The persons who are having wide eyes, they will be having a great visual field. The persons who are having narrow eyes, they will be having low visual field. Right? So just write there, guys. The person with wide eyes will have greater visual field, and person with narrow eyes will have lesser visual field, right? So remember guys, I told you in the beginning, while discussing the anatomy, I told you one small nerve leaves the eyeball, and the beginning of the optic nerve, that nerve is called as optic nerve. The beginning of the optic nerve is called as optic disc. That is also regarded as a blind spot of the eye. So basically remember, where is this blind spot present? Blind spot is present on the temporal visual field. Just right there. Why do you call it as blind spot? Why it is optic disc regarded as a blind spot? Why? Because there is no rods or no cones present over there. Okay? So remember guys, blind spot is what, guys? Optic disc. Where is this optic disc located? This is located on the temporal visual field. It is located on the temporal visual field. Temporal visual field. Right? So this was regarding what, guys? This was regarding the visual field. But it doesn't mean that visual field is done. No. Remember, guys, remember, whenever you are checking your superior visual field, what part of the eye you are checking? You are checking basically the retina. But remember, fields and retina is always opposite. यानी कि fields and retina is always opposite. When I am checking my superior visual field is basically helped by inferior retina, inferior part of the retina. Okay, inferior field, superior retina. Temporal field, nasal retina. Nasal field, temporal retina. So visual fields and retinas are always opposite, right? Superior visual field is held by what retina? Inferior retina. Inferior field is held by superior retina. Temporal field is held by nasal retina. Nasal field is held by temporal retina. Yani ki basically, if a person is there who's coming to your clinic and while checking his visual field, you come to know that he is having a superonasal field defect. Yani ki he is having a visual field defect of superonasal. Yani ki superior, while looking at the superior and the nasal side, he is having some visual field defect. Which part of the retina is problematic in that person? If a person is coming with a superonasal visual field defect, what part of the retina is responsible? It is the opposite of the visual field defect. The field defect was seen in the superonasal, right? So the opposite of superonasal will be inferotemporal. Yani the patient will be having problem in which part of the retina? Inferonasal part of the retina, right? So if there is superonasal field defect seen, then the lesion will be on the inferotemporal retina. Inferotemporal retina, right? Next, just strike this off, guys. Optic disc is placed at nasal retina. No, optic disc is placed. We'll start from this point. So if the superonasal, if the patient is complaining of superonasal field defect, where is the lesion? The lesion will be the opposite of the field defect. What is the opposite of this field defect? Inferotemporal retina. Inferotemporal retina, right? This is regarding the visual field, right? So for visual field, I told you what is the device that is used to measure the visual field. For measuring the visual field, we need to go for a device which is called as perimetry. Apart from perimetry, there are some other methods to measure the visual field that is called as campimeter or Amsler's grid. Campimeter or Amsler's grid. Patients who are having a decrease in the visual field, they might become blind. Right? So this is regarding what, guys? This is regarding the visual field. Visual field is basically the area of space seen by the eye without moving the eye from a fixed point is called as visual field, which is measured by perimetry, right? Visual field, I told you, superior is there, nasal is there, temporal is there, and inferior is there. The smallest or the shortest is the nasal, the largest or the longest is the temporal field. Okay? Spectacles, if you wear spectacles usually decrease the incidence of visual field. Why? Because when we are wearing spectacles, my temporal field will be reduced. Why? Because of the specs, right? Contact lenses increases the visual field. Greater eye, like if at all the patient is having a wide eyes, greater visual field. Narrow eyes, decreased visual field. Okay, that's regarding visual field. Now coming to what, guys? Color vision testing. Color vision testing, right? Now guys, you might have seen or you might have heard about this color vision problem. There are many persons having problems to differentiate, problems to identify or problems to distinguish between the colors and all. Remember, guys, color vision problem is seen due to problems in the pigment in the eye that helps us to differentiate the color. What is that problem? If the patient is having deficiency of cones, then he will have the color vision blindness, right? Cones is the pigment that helps us to differentiate the colors. So if the patient is having deficiency of the cones, then the patient will have color blindness. But why is the Why is the deficiency of the cone seen in this patient? Why? What is the reason for it? Remember guys, color blindness usually it's a product of consanguineous marriage. Consanguineous marriage means what? Marriage with the first cousins or marriage with the relatives. So that's why we discourage this. Whenever a person is color blind and all, we always, I'm not telling that it is the only cause, but it is the most important cause of color blindness. Consanguineous marriage is the most important cause of color blindness. Okay. So guys, remember, females can't be color blind. Color blindness is basically an X-linked recessive condition. It's an X-linked recessive condition. Males can be colorblind. 10% of the males can be colorblind, but females cannot be colorblind. Why? Because it's an X-linked recessive condition. If a person is having color blindness, he will be basically having problem to differentiate between three colors. Either he is not able to see the green color, either he is not able to see the blue color, or either he is not able to see the color vision. Either the patient will start from here, will continue from here. Color vision the patient either is not able to see the green color, either he is not able to see the blue color, or either he is not able to see the red color. These are the very important colors, yes or no? And remember guys, we never allow the color blind patient to drive. If we allow them, what will happen? They can't differentiate the green color and red color, and there might be accident seen. So guys, remember, color blindness is basically a condition which is seen as an X-linked recessive disorder, commonly seen in males, right? Commonly seen in males, but females cannot be color blind. Okay. So guys, remember, what is the test done for detecting this color blindness? The test that could be done for detecting color blindness is Ischiaris chart. You can see this chart. You might have seen this chart. I saw this chart while I was studying in the 6th or 7th standard. In my textbook, at the back side, this chart was given and some number was being hidden in this chart. Right? They told me to identify the number which is being hidden in this chart. Basically, it was written in the text. Okay? So this is called as Ischiaris chart. Ischiaris chart. Apart from Ischiaris chart, they will show you some 100 colors and tell you to identify the most important colors over there. That is called as FM100 hue test. Apart from FM100 hue test, there is one more test that could be done for detecting the color blindness. That is called as Nagel's anemaloscope. Nagel's anemaloscope. So 3 tests can be done for detecting color blindness. What are the 3 tests? Ischiaris chart, FM100 hue test, and Nagel's anemaloscope. The term that is given to color blind people is called as daltonism. Okay? Now guys, in this color blindness, there will be 2 conditions. One patient will be having color weakness, other patient will be having color blindness. I'll tell you guys what is color weakness and what is color blindness. Now guys, color weakness means imagine a person is sitting over here and he's saying that imagine there is a red color chart that is being shown to him. He's telling that, doctor, I am able to see the chart. I am able to see some orange color. It is bright red, but he's telling what? I am able to see the chart color is orangish color. So, he is able to identify the color, but he is having some weakness to identify the exact color, that is red. So, if the patient is having color weakness, it is called as anomaly. It is called as anomaly. Okay? Other patient will be there. They will be showing chart to him and he'll be telling the doctor, I'm not able to see any color on that. That means what? Red color you are showing to him and it's telling that I'm not able to see it. Yani ki if he is not able to appreciate the color, then it is called as anopia. Color weakness is called as anomaly. Color blindness is called as anopia. Okay? So remember guys, I told you 3 colors are very important over here. Red color, green color and blue color. Right? Red color weakness is called as protanomaly. Red color weakness is called as protanomaly. Whereas red color blindness is called as protanopia. Okay? Green color weakness is called as deutanomaly. Green color blindness is called as deutanopia. Next is blue color. Blue color weakness is called as tritanomaly. Blue color blindness is called as trabecular, which is common among these three. We have to remember that. Okay? We have to remember that. Okay? So remember guys, red color blindness is called as what? Protanopia. Remember, the most common color blindness that you see is what? The green color, weakness and blindness. The rarest is what? Blue color. Blue color. Blue color weakness and blue color blindness is right. Red color weakness is called as protanomaly. Protanomaly. Blue color weakness is called as tritanomaly. Tritanomaly. And green color weakness is deutanomaly. Okay. Most commonly that you see is green color blindness as well as green color weakness. The rarest is what guys? Tritanopia and tritanomaly. Tritanopia and tritanomaly. So I told you this color vision is basically coming from the cones. They are three different color, three achromatopsia, right? I also told you we never allow the color blind to drive. I also told you that it is a product of consanguineous marriage. That's why a genetic counseling is being done before marriages. If at all consanguineous marriages are, genetic counseling is being prescribed, but no one does it, but still it is being prescribed whenever anyone goes for a consanguineous marriage, so that the color blindness doesn't occur. Now guys, I told you there are two pigments in our eye. One is called as rods, other is called as cones. One is called as what? Rods. Rods means what? Rods is rhodopsin. Rods helps in what vision? Rods helps in what vision guys? It helps in the night vision, dim light vision. Okay. Cones helps in color vision. Cones helps in color vision or bright vision. So rods helps in the dim light vision or night vision, whereas cones helps in what? Remember, rods are cylindrical structures. 120 million rods are there. 120 million rods are there. Rods are present on the periphery. These are responsible for night vision, peripheral vision. Whereas cones are present in the center. These are responsible. How many millions are cones? 6 million. Cones are 6 million. Responsible for what? Color vision. Responsible for color vision. So remember guys, rods are at the periphery, responsible for peripheral vision as well as night vision. Cones are at the center. They are responsible for the central vision as well as color vision. So rods are 120 million at the periphery, usually responsible black and white and night vision and peripheral vision. Cones are 6 million in number. They are at the center for color vision, daylight vision as well as for what vision? Central vision. Central vision. Okay. That's the differentiation between the rods and cones. That's the differentiation between the rods and cones. Okay. So once again I told you, color blindness is called as anopia. Color weakness is called as anomaly. The most commonly seen color blindness is called as what guys? The most commonly seen color blindness is called as what? Most commonly seen color blindness is? Come on, deutanopia. And most commonly seen color weakness is deuteronomy. Okay. So that was regarding what? That was regarding the color blindness and color weakness. Now coming to what, guys? Now coming to the ocular movements. When you move your eyeballs, your eyeball moves in up direction, right, left, down, up right, up left, up down, down right, down left. These are the movements. These movements of the eyeballs are usually occurring with the help of what? With the help of muscles. They are muscles supporting the eye, yes or no? Right? There are 10 muscles of the eye. 7 are the extraocular muscles, 3 are the intraocular muscles. 7 are what, guys? Extraocular muscles, 3 are intraocular muscles. The 3 intraocular muscles are what? The levator pupil, the 3 intraocular muscles are what, guys? The ciliary muscle, the sphincter pupillae and the dilator pupillae. The ciliary muscle, the sphincter and the dilator, these are the intraocular muscles. Wait a bit, guys. Intraocular and extraocular muscles. If I ask you the derivation, where is the extraocular muscles derived from? What is your answer? What flashes to your mind? What thing flashes to my mind is the mesoderm. From mesoderm, extraocular muscles come. Intraocular muscles come from what? Neural ectoderm. Okay. So the derivations we know. What we are discussing is 10 muscles are there. 3 are intraocular. One is the sphincter pupillae, other is dilator pupillae, and last is what, guys? Ciliary muscles. These are the 3 intraocular muscles. And how many extraocular muscles are there? 3 intraocular muscles are. We'll start from here. 3 intraocular muscles are the ciliary muscle, the sphincter pupillae, and the dilator pupillae. Whereas the 7 extraocular muscles are what? 4 rectus, 2 oblique, 1 supplying the eyelid. 4 rectus, superior rectus, inferior rectus, medial rectus, lateral rectus. Superior oblique, inferior oblique. Yani ke 4 rectus muscle, 2 oblique is done. And 1 supplying the eyelid, which is what? LPS. What is LPS? Levator palpebrae superioris. LPS. What is the function of LPS muscle? This is the muscle that helps us to open the eyelid. Okay? This is the muscle which helps us to open the eyelid. Once this muscle gets tired, then frontalis muscle helps us to open the eyes. Okay? LPS muscle is levator palpebrae superioris. To close the eyes, to close the eyelid, it is not LPS muscle. To open the eyes, it is the LPS muscle. To close the eyes, there is orbicularis oculi muscle. Orbicularis oculi muscle. So anyways, guys, we are talking about what? Intraocular muscles are sphincter pupillae, dilator pupillae, and ciliary muscle. Extraocular are what? 4 rectus, 2 oblique, and 1 levator palpebrae superioris. Okay. So 4 rectus muscle are superior rectus, inferior rectus. Okay. We have, do we see it? Okay. First just right there, guys. Right there. Right. 7 extraocular muscles are divided into 1 supplying the eyelid. And then there are 6 muscles. Just right there. The one which is supplying the eyelid is what? LPS. What is LPS? Levator palpebrae superioris. Levator palpebrae superioris helps to open the eyes. But once it gets tired, frontalis muscle helps us to open. Frontalis muscle takes the role of it. Takes the role of it. That is LPS, levator palpebrae superioris. Okay? Apart from that, what else we need to remember is, what is the muscle that helps us to close the eyes? It is the orbicularis oculi. Orbicularis oculi closes the eye. It closes the eyes. Orbicularis oculi closes the eye. Now guys, I told you these muscles. How many muscles are there? 3 intraocular, 7 extraocular. In 7 extraocular, what we need to remember? Superior rectus, inferior rectus, superior oblique, inferior oblique, medial rectus and lateral rectus. Okay. Then one is the LPS. Now guys, all these muscles are helping us to produce some gaze of the eye. What are the gaze that is being produced by the eye? First gaze is what? Straight. Second, up. Third, down. Okay. Fourth, left. Fifth, right. Sixth, up and right. Seventh, up and left. Eighth, down and right. Last, down and left. Yani ki in together, how many gazes are produced by the eye? 9 gazes are being produced by the eye. Now there have been questions about what is the function of these muscles? Okay? To remember the functions of the muscles, you have to remember a small mnemonic so that you can remember all the functions. The mnemonic is SYNRAD. The mnemonic is what, guys? SYNRAD. We have discussed all the gazes and all. What's the mnemonic to remember? SYNRAD. What is SYNRAD? Superior in thoughts. Superior in thoughts. And RAD means what? Rectus adducts. Rectus adducts. Superior in thoughts, rectus muscles, adducts. Okay? So if it is a superior muscle, it will intort. If it is an inferior muscle, it will extort. Okay? Remember guys, remember, I am a superior person. I am a superior person. Imagine I am a superior person. I'm having much ego and all. I'm a superior person. I'll be walking like this. My eyes are on the sky. What will happen? While I walk, my eyes are on the sky. If there is a small speed breaker also, I'll fall down. So, a person who is superior always will fall down. Superior always intorts. Inferior always extorts. Inferior always extorts. So, one function we can remember. Rectus. If it is rectus, it will cause adduction. Rectus will cause adduction. SYNRAD is the mnemonic, guys. Rectus adducts. If it is oblique, it will cause abduction. It will cause abduction. If it is oblique, it will cause abduction. Now guys, look over here. Look over here. If you just remember this mnemonic, all muscles function, you can easily remember. So now, there was a question for superior rectus. What is the main function of the superior? What is the function of the superior rectus muscle? As it is superior, it will cause intorsion. The second function, first of all, superior, so it will cause intorsion. Next, it is rectus, so it will cause adduction. You have to just remember the main function. Superior causes intorsion and adduction. With that, it will also cause elevation. Next is what, guys? Inferior rectus. If it is inferior rectus, what will it cause? Inferior, it will cause extorsion. Plus, it is rectus, so it will cause adduction. So, extorsion and adduction. Next, superior oblique. Superior oblique. Superior means what will it cause? Superior, so it will cause intorsion. With intorsion, what will it cause, guys? With intorsion, it will cause what? It is oblique, so it will cause abduction. It will cause abduction, right? So, intorsion and abduction, superior oblique. Okay? Inferior oblique, inferior means it will extort and it will cause abduction. Abduction. So, these functions you can easily remember, right? So, these are the functions. Elevation, depression and all, but are not that important, but the important functions are, remember, if you remember this mnemonic, you can easily remember it, guys. SYNRAD is the mnemonic. Superior intorts, rectus adducts. Rectus adducts, right? So, each muscle is having primary, secondary and tertiary action. The primary action of superior rectus is elevation, whereas inferior rectus, it is depression. Depression. Okay? Inferior rectus is the muscle which is most commonly affected in a patient who is suffering with thyroid disorder and suffering with thyroid ophthalmopathy, yani ke proptosis. In proptosis, the most commonly affected muscle is the inferior rectus muscle. Inferior rectus muscle, right? Now, remember guys, the anterior, posterior, remember other muscles for superior oblique are there, superior rectus is there, orbital fat. These are the things that provide the stability to the eyeball, right? Remember what stability? The anterior, posterior stability to the eyeball is provided by superior rectus, superior oblique and orbital fat. Orbital fat. So once again guys, we are talking about the muscles of the eye, which are 3 intraocular and 7 extraocular. 7 extraocular muscles means what? 1 supplying the eyelid and 4 rectus and 2 oblique muscles. Okay. So this was regarding what guys? This was regarding the ocular muscles and ocular movements. Okay. Now guys, imagine, just look over here. Imagine I tell you to move the eye towards the right side. What will you do? You move the eyes towards the, imagine I tell you move to the right side. You will move your eyes towards the right side. But can you do this? This means what? I tell you just to move your one eye to the right side, other eye in a normal position. Is it possible? No. No. When you tell the patient to move the eye to the right or left side, both the eyes will move in that direction. Right? Why? Because in the other eye, there is a pair of muscle called as yoke muscle that helps in contracting and moving the eye in the same direction. Right? So remember guys, yoke muscles are pair of muscle from the opposite eye. When they move or contract, they move the eye in the same direction. What is the nerve supply of the eye, guys? What is the nerve supply of the eye? For nerve supply of the eye, we have to, or for nerve supply of the muscles of the eye, we have to know a formula. I used to remember this formula, LR6, SO4, and LR6, SO4 and others 3. LR6, SO4, others by 3. If it is lateral rectus, it is supplied by 6th cranial nerve. Superior oblique supplied by 4th cranial nerve. And all other muscles are supplied by 3rd cranial nerve. So once again, what's the formula guys? LR6, SO4 and all others by 3. There have been questions guys. These muscles which are helping in the movement of the eye, they are having nerve innervations and nerve supplies. What is the formula for it? LR6, SO4, others by 3. Lateral rectus means supplied by 6th nerve, superior oblique supplied by 4th nerve, and other muscles of the eye are supplied from 3rd cranial nerve. 3rd cranial nerve. All others or rest others are supplied by 3rd cranial nerve. There have been questions about what? Where is this nerve nucleus located? Where is the nucleus of the 3rd nerve located? The 3rd nerve nucleus is located in the upper part of the midbrain. At the upper midbrain. 3rd nerve, it is upper side. 3rd, 3 comes at the up. 3 is the high number, right? 3 is the high number. When you compare, remember we are discussing about 3 nerves only. What 3 nerves? Because 3 nerves are only supplying the eye, right? LR6, SO4, all others by 3. Lateral rectus supplied by 6th nerve, superior oblique supplied by 4th nerve, and others are supplied by 3rd cranial nerve. So, the 3rd cranial nerve nucleus, where it is located, as 3rd is a higher number, it is located in the upper midbrain. Next, after 3rd, 4th. 4th cranial nerve nucleus is located where? Lower midbrain. And 6th cranial nerve, 6 is the lower part, lowest. So, its nucleus is located where? At the pons. Right? So, this have been an MCQ. The 3rd cranial nerve nucleus, where it is located? It is located at the upper midbrain. 4th cranial nerve, lower midbrain. And 6th cranial nerve nucleus is located at the pons. It is located at the pons. Okay. So this is regarding what guys? This is regarding what? This is regarding the introduction. Okay. We'll discuss the convex lenses, concave lenses while discussing the optics and refraction. Okay. So this was regarding the introduction of your ophthalmology. Thank you guys.